what occlusion is in simple terms. Forget about the definition. Can you see my screen right now? Can you people see my screen right now? Yes, good. The contacts between the teeth. What else? Forget about the definition written on the screen and tell me what occlusion is in your terms, in general terms, simple terms. What do you understand about occlusion? You can open your mic and speak if you want to. If you don't want to write, you can speak. Yes, good relation between upper and lower teeth. What kind of relation it is? Anybody else, please? Why it is important for orthodontist to know the normal occlusion or the occlusion so that he can recognize the problems, the abnormalities in the occlusion, right? So every dentist should know what occlusion is, how does it look like, what are its principles, so that you can differentiate between the normal and the abnormal occlusions. As written here, the occlusion is a complex phenomena involving the teeth, the periodontal ligament, the jaws, the TMJ, and the muscles, as well as the nervous system. And occlusion is it a static condition or a dynamic condition? Is occlusion static or dynamic? What is the meaning of dynamic? What is the meaning of dynamic? Moving, exactly. So occlusion is considered as static, right? There are different types of occlusions which are dynamic and static. The maximum intercuspation between the maxillary and the mandibular teeth is called as occlusion, which is static. Am I right? So the next question comes, what is the ideal occlusion? There is nothing which is ideal in this world. This is just a theoretical or imaginary concept of occlusal structures and functional relationships that includes the idealized principles and characteristics that an occlusion should have. But there is no ideal occlusion as such in the world, right? So the maximum intercuspation, which is achieved in an individual without any abnormalities within the functional limits, is considered as occlusion. Yes, the occlusion which actually exists is physiological occlusion, that is called as normal occlusion, which refers in definition terms the occlusion that deviates in one or more ways from an ideal occlusion, yet it is well adapted to that particular environment, is aesthetic, physiological, functional, without any pathological manifestations or dysfunctions, right? So there is nothing which is called as ideal occlusion. It is just a theoretical concept, whereas the normal and the physiological, you cannot hear me? So the physiological occlusion is what? Which is deviated from the ideal occlusion, but in one or more ways that is well adapted to the physiology and the function without any pathology. Now, next comes the balanced occlusion. Can anybody please tell me what is balanced occlusion? I'm telling again, if you don't want to write, you can speak. You're allowed to speak. So please tell me what is balanced occlusion. Forget about the definition written here. Whatever you understand about balanced occlusion, tell me, please. Equal forces, yes. What else? Yes. Usually, all teeth does not get contact. Even if all teeth are not in contact, it is considered as balanced. But the balancing, there are cusps which are known as balancing cusps and supporting cusps, right? So, occlusion, functional and non-functional cusps. So, starting from the static occlusion, where we find the maximum intercuspation when an individual moves the mandible forward or lateral. It should have balanced contacts and equal contacts. So, an occlusion in which balanced and equal contacts are maintained throughout the entire arch during all excursions of the mandible, that is, forward or lateral. Now, what is functional occlusion? It is defined as the arrangement of teeth which will provide the highest efficiency during all the excursive movements of mandible which are necessary during function. It's same as balanced occlusion, right? Means when mandible moves, teeth, the balancing cusps should maintain the occlusion during all the excursions. Now, there is one more term which you will be listening: therapeutic occlusion. An occlusion that has been modified by appropriate therapeutic modalities, means by orthodontic treatment or any prosthodontic treatment, in order to change a non-physiological, that is pathological occlusion, malocclusion, to one that is at least physiologic, if not ideal. As I said, occlusion will never be ideal, it will be physiological. So therapeutic occlusion is one which is treated. Balanced occlusion is actually dynamic, because in the start I asked you what is occlusion. Is it static or dynamic? So occlusion is considered as a static one, while balanced occlusion is considered as dynamic during movement. Right? It's same. The maximum intercuspation is maintained during movement is balanced occlusion, whereas the occlusion is at rest. Am I clear? The next is traumatic occlusion. Traumatic occlusion is an abnormal occlusion due to the abnormal occlusal stresses which is capable of producing or has produced an injury to the periodontium. Trauma from the occlusion is defined as a periodontal tissue injury caused by occlusal forces through abnormal occlusal contacts. Now, there are some imaginary occlusal planes and curves that exist in normal occlusion, ideal occlusion. I'm sure you must have heard about the curve of a SPI. It is referred to as the anterior-posterior curvature of the occlusal surfaces beginning at the tip of lower cuspids, mandibular canines, and following the cusp tips of the bicuspids, that is premolars and molars, continuing as an arc through the condyle. That is a curve of a SPI, which is very important in the normal occlusion. For prosthodontist, for orthodontist, it's a very important curve. The second curve is known as the curve of Wilson. It's a curve that contacts the buccal and lingual cusp tips of the mandibular teeth. The curve of Wilson is a mediolateral curve. Curve of a SPI is an anterior-posterior curve. It moves from the canine towards the condyle. Whereas the curve of Wilson is a mediolateral curve, right? It is joining the buccal and lingual cusps of the mandibular teeth. It results from inward inclination of the lower posterior teeth. It helps the occlusion in two ways. Number one, The elevated buccal cusps prevent food from escaping out of the occlusal table. Second, they are aligned in such a way that the optimum resistance to masticatory forces is given. Curve of Monson is obtained by extending the curve of Spee and curve of Wilson to all the cusps and incisal edges. If you extend these curves in the anterior region or anterior to the canine, you will get the curve of Monson. So, as I said, physiological occlusion exists, the normal occlusion exists. There must be some rules that why and when you are telling some occlusion is a normal occlusion and not abnormal. So there are certain keys explained by Andrews, the student of angles, which is considered as the father of modern orthodontics, has explained 6 keys of occlusion, which you should remember. I hope you all know about these keys. If yes, please tell me. If you don't know it, I will go in detail. Otherwise, you will just have a review and move forward. Do you know these 6 keys of occlusion already, or you want me to explain in detail? I'm asking you people, do you know these 6 keys of occlusion already? So I will just have a review and move forward. Okay. Okay. So what are these keys? The first key, okay, the first key is molar relationship. We should know how the molar should look like in a normal occlusion. The molar should be in class 1 relationship. What is this relationship? As you can see here in the picture, the mesiobuccal cusp, the mesiobuccal cusp of the maxillary permanent first molar, the mesiobuccal cusp of the maxillary first permanent molar should coincide with the buccal groove of the mandibular first permanent molar. This is considered as class 1 molar relationship. So all normal occlusions should have class 1 molar relationship, that the mesiobuccal cusp of the maxillary permanent first molar should coincide with the buccal groove of the mandibular first permanent molar, right? And at the same time, if you can see the distobuccal cusp is coinciding with the mesial slope of the mandibular second molar. This is the normal class 1 relationship of molar, right? Now, the second key is crown tip or angulation. Does anybody tell me, know that what is tipping and what is torque? What is tipping and what is torque? The crown tip is actually considered as the mesiodistal tip. If you see the long axis of the tooth, if you see the long axis of the tooth, you can divide it into two halves: the gingival half and the incisal half. If you see the crown, the part of the tooth which is visible in the oral cavity can be divided into two: the gingival portion and the incisal portion, right? So, what is crown tip or angulation? Crown tip is considered as a mesiodistal tip, refers to angulation of the long axis of the crown. In normal occlusion, the gingival portion of the long axis of each crown is distal to the incisal portion, right? The degree of crown tip is the angle between the long axis of the crown and a line bearing 90 degrees from the occlusal plane. So, all the teeth, the crown tip is positive in both upper and lower teeth, with all the teeth showing a mesial crown inclination. Mesial crown inclination means the mesial half of the teeth, so the incisal portion of the tooth is mesial to the gingival portion of the tooth. If you see both central incisors from the front, from the labial aspect, what you see is both the incisal edges are coming together, and the distal halves, the gingival portion, is distally to the incisal portion. That is known as normal crown tip. That all normal occlusion should have a mesial crown tip. The third key is crown inclination, which is considered as a buccolingual angulation or buccolingual inclination, which is also known as torque. So, crown angulation, the second key was mesiodistal. The third one is crown inclination, that is torque. Torque is expressed as plus or minus. Here, you see the long axis of the tooth, buccally and lingually. A plus reading is given if the gingival portion of the tangent line is lingual to the incisal portion. A minus reading is given or recorded when it is labial to the incisal portion. So if you see from the side, if you see from the mesial aspect of the occlusion, you will find the incisors tilted labially, means the incisal portion of the crown is labial to the gingival portion. That is a normal occlusion, a key to normal occlusion. So the first one was molar relationship, that is class 1 molar. Second one was crown inclination, angulation, that is mesiodistal. The third one is crown inclination, that is buccolingual. Is it clear so far? Good. Here you can see the crown inclination, the positive 7 and 3. It is showing positive inclination, means the crown tip is labial, whereas the gingival portion is lingual. The fourth key is very easy. There should be no rotation. The teeth should be free of undesirable rotations. They should be aligned properly. If you can see here, if you can see here the marks, all the black spots, they are in one line. They are not rotated. They are not rotated. So there should be no crown rotations. The fifth key is tight contacts, means interdental contacts should be tight. There should be no gap in between the teeth, ideally. The fifth one is the occlusal plane. The sixth one is the occlusal plane. That is the curve of Spee. As I discussed before, it's an imaginary curve starting from the tip of the canine, mandibular canine, extending towards the condyle, right? Here, it is not exactly a curve. Here in orthodontic occlusion, we want it to be flat. A flat occlusal plane with minimum curve is actually desired in orthodontics, right? A flat occlusal plane with a minimum curve is desired in orthodontics. So, what are these 6 keys to the normal occlusion explained by Andrews? Number 1 is class 1 molar relationship. Number 2, positive crown angulations. Number 3, positive crown inclinations. No rotations, no spaces, tight contacts, and flat or minimal curve of a Spee. Right? So summary of this part of the lecture is occlusion is what is an occlusion? Is it static or dynamic? What is ideal occlusion? Does it exist or no? What is physiological occlusion? That is a deviation from the ideal occlusion, but in physiological range, giving proper structure and proper functions. Third, we discuss the dynamic occlusion, which is known as balanced occlusion. Once we move the mandible from static to dynamic, all forces should be equal, in equilibrium. Then we discuss the functional occlusion, therapeutic, traumatic, imaginary curves, curve of Spee, curve of Wilson, curve of Monson, their role in occlusion, and then we discuss Andrew's 6 keys. Okay, is it okay so far? If you have any questions in your mind, you can ask right now. Great. The second part is of our lecture today is malocclusion, but I will not go into the details of malocclusion. It will be This part will be discussed by Dr. Ibrahim Al Sharani, inshallah. But we will discuss the etiology of malocclusion today. But we will discuss etiology of malocclusion today. I'm sorry the lecture is extended, but because of the shortage of time, Dr. Shaheen told me to. Yes, balanced occlusion is dynamic. The term occlusion is actually maximum intercuspation knife, the maximum intercuspation at rest. And once we move from the static to dynamic, it is known as balanced occlusion. Occlusion can be dynamic, but it is termed as balanced occlusion or functional occlusion or articulation. You can properly say it as articulation. So